Hey there, what's going on? Dr. Rana here. Listen, I'm placing dozens of implants. I just graduated dental school a few months ago. I know the secrets. I can help you get to where I am today. All I ask of you is to please like, subscribe, and share this video with a friend who wants to get into implant dentistry now. All right, no secret about it. It's the hottest topic in dentistry today. Dental implants. It will change your practice forever. It'll benefit all patients that you're able to perform this for. Why? It's the best solution to a missing tooth, guys. Guys, you're not removing any other tooth structure adjacently like you would for a bridge. It's only additive. It preserves bone. It's the best long-term solution with success rates nowadays over 95 to 98%. Let's jump right into it. What do we have today? Today we have a 53-year-old Hispanic female, presents with missing dentition, broken teeth, caries all over, and she also presents with a medical condition called Bell's palsy. Bell's palsy is a total or partial paralysis of the facial nerve, cranial nerve number 7. Now, when I saw this patient, you can instantly tell she had it, right? Half of her face was weak. She couldn't express herself completely. She would be tearing up often in one eye. And I also noticed that she had a difficulty with producing saliva. And this is a dental condition with Bell's palsy. It's important to know that this condition can lead to an overproduction or a reduction of salivary flow, which, as we know, is a huge indicator for caries, and it puts the patient at a very high risk for caries through xerostomia or dry mouth. So let's take a look at the first clinical photo. What we see here is a patient with a lot of gum recession, cervical caries, a lot of missing dentition as well, mainly on the bottom and some on the top too. She's been complaining to me of having a terrible quality of life. She's never been able to eat properly as of late, and she used to have a partial. She threw that thing in the trash because she hated wearing it. And she was in a rush to get this case done. She told me a story about how she hasn't seen her brother in over 20 years since her childhood in Brooklyn. And now, since then, they've reconciled differences and they're gonna meet up for the first time in such a long time. However, she didn't want to be seen with half a smile, and she was afraid that she wouldn't be able to enjoy that evening dinner with him. So she read the positive reviews about me on Google, came to my practice, wanting some implants. So let's get her some implants, guys. Let's make an impact on somebody today and change somebody's life. But first, I'd like to bring your attention to the significant atrophy of that mandibular ridge. Guys, this is a great example of how tooth loss can destroy that underlying bone underneath it. And you should always show a picture like this to your patients to tell them why they need to fill those missing spaces, because this is an actual consequence of not getting dental treatment and not taking care of your missing areas. If you're in school, show a picture to your patients, or show this one to them. You show that to a female, it'll scare the shit out of them and they'll do any kind of treatment you're offering. A lot of the times, patients just don't know the consequences, and it's our jobs as healthcare providers to explain and educate the community around us so they have an idea of what to expect. Make sure you tell them that after a while, your bone's gonna shrink so much to the point where you may not even be able to get implants in the future. And this is a consequence you have to be prepared to deal with if we don't solve the issue today. Guys, there was an NIH study published saying that right after tooth extraction, up to 30% of that ridge, hard tissue and soft tissue, is being resorbed in some way. This is huge because this is what we need to get proper implant placement. And later in the video, you'll see what I have to do to create more space so we can place an implant when the patient has a really thin ridge. So I sat down and had a consultation with the patient. I told her the benefits and risks of going either regular denture route or implant supported. I told her, let's get 4 implants on the bottom. It'll preserve all the bone. It's the best option for you. It's an overdenture, so you'll be able to take it in and out, and it's gonna be an amazing improvement on your quality of life. So at the end of the consultation, we settled on a 2 implant overdenture. Snap in, comes in and out as needed, preserves bone in the anterior mandible. It's a huge improvement in her quality of life now, and it'll give her that stability when she's eating and when she's smiling and speaking that she's really looking for. And at this point, I don't even treat implant dentures anymore that are removable. I'm always offering a fixed solution. Guys, implants are the future. It is the next step that you must learn and you must get involved in, because implants will get cheaper, the technology to be able to place them is becoming more available, and it's just the next step, right? It's the iPhone 15. It is literally the next thing that everybody's seeking after in dentistry today, patients mainly. And if you've been following me up until this point, you know I'm using a sedative in this situation. You know my sedation protocol. I'm using diazepam and triazolam. I'm giving one the night before. I'm giving one an hour before the procedure. We're removing bone, flapping, extracting teeth, placing surgical implants. It's a no-brainer in this situation to have the patient more comfortable and sedated. You can check out my sedation videos right here if you need to. And if you want me to narrate more of these implant surgeries or my big full mouth cases, please hit that thumbs up, subscribe, and share this video with a friend. If you think dentistry is cool as shit or surgery is awesome, subscribe and leave a comment down below. Tell me what you think about this case, anything you would have done differently, or if you're just in awe, you're in school right now, you're just like, damn dog, that shit is dope, Dr. Rana. Let's see more. All right, now it's time to dive a little deeper into this case and start talking clinically. First thing I'm doing is I'm blocking both sides of the mouth with a 2% lidocaine, 1 to 100,000 epinephrine. I'm doing that, and then I'm using another carpule or two if I need to infiltrate all around the mandible, getting the gums blanching, try to infiltrate any tooth that still needs to be extracted, making sure the patient is completely numb and comfortable during this entire procedure. I start with the extractions. I'm using a spade elevator. You know my favorite instrument by now. I'm doing this to separate all the gums, getting some elevation on the teeth, and I'm going straight to the forceps. Guys, this extraction case was a walk in the park. My 2-year-old nephew could have done this. Literally, this man, if he tried hard enough, he can do it. This guy has the heart of a lion. And yeah, that's my 2-year-old nephew, Roman. He could have easily done these extractions. And this is a picture of him just being a bad boy, eating some karyogenic cake that I got him for his birthday. But it's okay. He deserves to be spoiled by Akash Kaka. And Akash Kaka? Yeah, Kaka. Kaka is uncle in Gujarati, and it doesn't mean poop. Anyways, I'm taking these teeth out with ease. I'm barely using elevators. I'm taking the forceps straight to the teeth and taking them out. There's so much bone loss that these teeth are very mobile. I don't need any elevators to do anything else besides use a forceps. Not that eventful, right? I know what you're thinking. Come on, Dr. Rana. Give me some blood. Let me see some big, massive surgeries, full mouth. Let me see some bone reduction. What's happening here, doc? You're losing your mojo. All right, hold on there. Let me tell you right now, it's coming right now. But first, please like and subscribe this video. Please share this with a friend who you think that finds implants super cool or dental surgery awesome like I do. It helps the YouTube algorithm and it helps me make more content for you guys. All right, let's get the flap going. Now we're talking. I'm making this flap mid-keratinized tissue. I don't use the word mid-crestal because that's a misnomer. Right, you want to preserve as much of that keratinized tissue on the buccal as possible. So guys, 15 blade to bone all around the arch, making sure I'm having a nice full thickness flap when I'm removing the gums in this situation. A little clinical tip that I do is that I like to take the PerioProbe or Explorer and go around the arch just to make a little map for me so I can connect the dots with the blade when I'm going through. I apologize for the crappy picture here, guys. Taking photos during massive surgeries is not the easiest thing, but I try to do it just to help you guys educate a little more and try to give you a glimpse into what it's really like to be in the operatory during these big surgeries. Next thing I'm doing is I'm taking that periosteal elevator to bone, moving the gums out the way, pushing really hard on the bone to remove all that periosteum. It's important to remove the periosteum, otherwise it's gonna start bleeding everywhere, guys. You wanna make sure that that's clean and out of the way. Oh baby, now we're talking. Guys, this is sexy. This is full-blown oral surgery right here. I love this kind of stuff. And if you're not excited about this, then you gotta find that other blogger on YouTube who's doing crown preps on plastic teeth, because this ain't that. This right here is textbook oral surgery, implantology. You heard it first right here. So what have we accomplished so far? Full thickness flap, all gums out of the way for proper bone reduction. And I really want you to appreciate the atrophy of that mandibular ridge. You have a much better understanding of how that bone has remodeled since those teeth have been gone. Just look at how thin it is up top. All of that needs to be brought down so we have a good thickness of bone and a lot of cortical bone to place these implants for long-term integration. All right, in the next picture, you'll see some bone reduction. Sweet. So now I'm using the 161 Lindemann burr to use for a bone reduction to level out that cortical bone. Guys, this is a very, very aggressive burr. This is what I use in my hands. It's not necessarily the best tool to use. It works for me, but if you are gonna use a burr like this, just look at how aggressive this thing is, first of all. Be very, very careful because it can remove a lot and it can nick a vital structure in the area as well. I'm always constantly checking the pano when I'm doing bone reduction. I use the little ruler to measure how far I'm away from the nerves, how much thickness of bone I have. These are all important things that are in your mind as a surgeon when you're doing these types of cases. As I'm leveling the bone, I remember in my earlier cases, I would always leave the lingual a little bit higher. So keep that in mind. You want the buccal height and the lingual height to be exactly the same, so you have a nice flat surface for your implants. And I also noticed some of that periosteum on the bottom there. I could have removed a little bit of that for better healing and less blood in the site. So these are things looking back at the photos that I've learned to make sure I don't do the next time. But here it is, guys. The time is now. The beautiful moment has arrived for surgical implant placement. I'm using the top of the line implants for my patients, the gold standard. This thing right here is called the Straumann BLX. It is the best implant on the market. This thing's got a 98% survival rating after 10 years, and it's specially designed to promote healing. And here we are, we're gonna start drilling now. We wanted to make sure we have at least 2 millimeters of bone, both buccally and lingually, mesial and distally. You wanna have a lot of space so that implant can integrate and be functional for the rest of this patient's life. We put them in the 22, 27 sites. We're using these guide pins and taking x-rays to verify, just to make sure we have good, proper angulation before we drill the final implant into the site. And I've officially got my certification in implantology. And if you're asking an implantologist if that looks good, oh baby, that looks beautiful. I'm super happy with those results, but thinking critically, I could have grafted that one implant site a little bit, but I'm not worried. I know that bone will heal in that site and it'll integrate perfectly fine. And just because you can place those implants, it doesn't mean that the surgery is done, right? We want to be able to suture it properly, get nice primary closure to promote the optimal amount of healing and long-term integration of those implants. All right, humble brag here, guys. I think this suturing job was freaking dope. I've been getting so much better at suturing because every extraction I've been tying up, I've been getting faster. I'm having better ideas of where to place the suture, better ergonomics of how to get around the tissue. And overall, my suturing game has gone up so much and I'm so proud of where it is currently. If you want to learn how to suture with swag, check this video I made. Guys, it's easy to learn, but it's difficult to master. Whenever I'm doing a full arch surgery like this, I'm doing a continuous interlocking from start to finish. I'm tying that first knot nice and snug, and I'm going through each one, making sure I get primary closure all along the ridge, and then finally tying that knot at the end. When I'm doing my continuous interlockings, that loop is getting smaller as I'm pulling the needle through, and then at that moment I twist the loop and I put the needle through it and give a nice little tug on that to lock that suture in with the continuous interlocking mechanism that the suture can provide. Continuous interlocking is my favorite suturing technique for a surgery like this. It allows me to work the entire arch pretty quickly. I don't have to wait for my assistant to cut the suture. I don't have to wait to reorient myself. I can run through the whole arch, tie it up at the end, and finally come over the continuous interlocking with single interrupteds just to make sure that nothing is gonna come apart anytime soon. And in my hands, what works best is 3/0 chromic gut. It's typically the standard. It gives me the right amount of thickness. Anything above 3/0, when I go to 4/0 or 5/0, it becomes way too thin and the suture breaks too quickly. I don't like how thin it can be, so I definitely like to stick to a thicker material. So 3/0 is my go-to. And here we are today. I'm feeling so grateful by God's good graces that I was able to land my dream job. I'm able to make an impact on all my patients, and I'm able to change people's lives through the treatment that we can provide as dentists. I know that feeling of being able to give somebody the gift of a smile, or to give somebody the ability to be able to chew their food properly. That feeling to me is priceless, and I want to give that feeling to more people in the world. And I can't wait to have that conversation with my patient, asking her how that moment felt for her. How was she feeling when she got to see her brother again in 20 years? How was that meal that she was able to enjoy with him after all this amount of time? I know I was able to make an impact on her life, and I know the value that we have as dentists in our community and around the world. So that's my job today, is to just explain and bring awareness to our field, how beautiful it can be, and just help another person get to where I am today. Guys, if this video made an impact on you in any way, please share this with a friend, drop it in the group chat, like and subscribe, leave a comment down below if you thought it was cool or if you would have done anything differently. I'm curious to know what you think. Please, if you need to, follow me on Instagram, message me there. We can always have a conversation. I'm always here for you. And until next time, guys, take care. Dr. Rana clocking out.